Hello, welcome back. I'm Dr. Mark, and today we are talking about the main complications and the most severe and the most life-threatening complications we can have in a patient with the diagnosis of diabetes. There are a vast number of complications we can have in these patients, so I am only including the 7 I consider the worst or the most life-threatening or the most frequent that lead to a severe disability. So, of course, if you have any other complication, you can talk with your physician, and I will also leave some resources in the description, in this video's description, so you can check out more content. Having diabetes is a very severe risk factor for our cardiovascular health. It's such a risk factor that it's considered just as bad as smoking or having a high cholesterol level. So what we have to do is, of course, in a patient with the diagnosis of diabetes, check these other risk factors. We have to check, of course, if the patient smokes, has a high blood pressure, a high lipids in the blood, cholesterol, for example, triglycerides, obesity, any other thing that might also affect our patient's hearts, and contain it. Try to diminish that risk factor. Along with, of course, controlling properly diabetes, having a proper glucose level in our blood, that will also bring the risk lower. If we fail to do this in the first stages of our patient with diabetes, then we are going to have a patient with a heart attack or a stroke. And of course, that is a very different scenario from a patient with risk factors to a patient with a stroke or a heart attack. That is a much more difficult case, and of course that's a patient that suffers a lot more. So we have to be very strict with measuring the cardiovascular risk factors for our diabetes patients. Neuropathy is another very serious cause of disability in our patients. We're going to talk a little bit more in the next points. Here we could mention, of course, pain, diabetic neuropathic pain. That is a very severe and a very disheartening and disabling pain that patients feel. That is sometimes very difficult to control. We have other types of course, neuropathy affecting the process our patients need to walk or to feel things, a lot of things. But the most severe case of neuropathy that we find in diabetic patients is of the nerves that, of course, go to our heart. Our heart needs our nerves to maintain a proper rhythm. So these nerves tell the heart to go faster or go slower, depending on what we're doing. To beat faster if we stand up, to beat slower when we sit down. So when we have these nerves affected, this may lead to severe arrhythmias. And these arrhythmias may even lead to the patient's death. So we have to be very strict with detecting neuropathy. If we find peripheral neuropathy in our feet, in our hands, we know that this neuropathy comes or has a distribution called of socks and gloves because it affects primarily our feet and our hands. So we have to explore this neuropathy, this peripheral neuropathy, in every consultation, in every doctor's office appointment, to find the first signs of neuropathy and start understanding or start mapping when this very or much more severe neuropathy will appear. Fortunately, autonomic neuropathy, the one that affects our heart or the one that affects also our intestines, and it may lead to gastroparesia, complication where we can't eat. It's very difficult for the patient to eat. Those are those usually appear much later on a patient's diagnosis. So if we, once again, detect first the peripheral, the one that we find in hands and feet, we can detect and prevent with an adequate glucose control and, of course, with the monitoring of those nerves when the autonomic neuropathy appears, and we can prevent those very severe and life-threatening arrhythmias. Infections are also very common in our patients with diabetes because they have a low immune system and because of other risk factors these patients particularly have. The thing is, when a patient develops an infection, very commonly a urinary tract infection or an infection in their feet, their own body, their own immune system can't contain it. So the bacteria, the fungus, the viruses start spreading, and they might cause very severe infections like pneumonia or like pyelonephritis or another type of severe infection. And even the most severe or the most severe form of an infection that it's called sepsis, or a generalized infection. Sepsis is a point where the infection was so severe that our immune system completely went nuts and starts attacking us. Not like an autoimmune disease, but like a very severe dysfunction of our body and of our immune system. So what we have to do is be very vigilant with these patients with the diagnosis of diabetes, detect infections right when they are starting. So when they start with manifestations of urinary tract infection, checking their feet constantly, checking their lungs, and of course preventing these infections. For example, in the case of pneumonia, we have to ensure our patients with diabetes have the proper vaccinations, like the pneumococcal vaccine, pneumococcal vaccine when they are over 65 years old, influenza if every year on December or on winter season, and finally COVID, or all of their COVID vaccines. This way we protect the appearance of an infection, and of course we don't let it get overboard and don't cause severe infections and sepsis. One of the most famous and severe complications of diabetes is of course amputations. Usually amputations appear because patients, one of the main sites of things going wrong are the feet. The feet are very far away from the heart, very far away from the nerves, so they usually have neuropathy, or it's one of the first places where this appears. They usually have a compromised vascular irrigation, so the feet are usually very vulnerable. So in our patients with diabetes, it's also very common for an ulcer to appear, a very small lesion that in any patient it would just heal, but in these patients, and a bacteria starts crawling in, the lesion starts proliferating and of course causes an infection. And as we said in the previous point, once the infection appears, it's very hard to contain it. It grows and grows and grows, and it can infect not only skin, also muscle, blood vessels, the bone, everything. And then it reaches a point when we can't contain it with drugs, with antibiotics, and we have to cut the feet, the hands, any other part of the body that was affected with these types of infections. Once again, the main site where we see these types of infections and amputations are the feet, any of the feet, but some patients also can develop these types of infections in their hands, and they sometimes need also to have an amputation on their hands. It's not as frequent because once again they are closer, they don't suffer neuropathy as soon as the feet. It's much easier to take a look at my hands and see if there's a lesion. I use them more, they're not covered with the shoe, so all of these things make it less frequent in the hands, but it can appear. So in the feet, what can we do to protect them? Of course, check them every day in patients with diabetes. Check that there are no lesions, and if there are any lesions, check that they start to heal in the next few days, that they don't show signs of infection, like they are red, like they are secreting pus, or they have another liquid coming out of them, using the appropriate shoes, so comfortable shoes that don't cause ischemia, that don't cause the deformation of my feet, etc., etc. And of course, always checking with my physician that my feet are completely healthy. Diabetes can also be a terrible, terrible killer of our senses. Of course, probably the most famous and the most severe alteration of our senses is all of the compromises, all of the diseases that diabetes causes on our eyes. It can cause even blindness through diseases like diabetic retinopathy or also cataracts. And these are usually, and it's very sad because these diseases are usually very, very manageable. So if we detect them at the beginning, we can treat them relatively easily and cheaply, but when they are much more advanced, they are impossible to treat and the patient will lose their eyesight. So once again, it's very important to detect them when they are starting through the revision with an ophthalmologist at least once a year for patients with diabetes. However, our vision is not the only organ or not the only sense that is affected. Diabetes also can affect our sense of touch through the neuropathy, the peripheral neuropathy. It can affect our proprioception, that is the perception of the position of my body, that is also required to walk. So it can also lead to severe walking problems because this alteration in the nerves that tell our brain in which position are our legs, our feet, and the rest of our body. And it can also affect our hearing. So it can also damage the nerves and the structures needed to hear and cause deafness. They can affect all of the senses, but those are like the main three that lead to severe disability. First of all, our eyesight, second, our touch and our proprioception, and third, of course, our hearing. We've talked in previous videos about how diabetes can affect severely our kidney function. From the first glucose peaks we have in our blood, those directly arrive to our kidney and start damaging the proteins and the cells in our kidneys. So how can we detect it, since the damage done to our kidneys doesn't generate any sensation, any pain, anything? We have two types of studies. The first ones, the ones that we can detect the kidney damage from very early on. It's a test called microalbuminuria. It's not the only one, but it's one of the most used tests. And it can detect fairly quickly that our kidney is already receiving lesions or being damaged by excess of glucose and, of course, diabetes. The second study, it's more precise, but it only detects kidney damage when it's much further down the line, much closer to needing dialysis of some sort or even a kidney transplant. And that is of course creatinine clearance. It's a complicated study to take. Microalbuminuria is much more easy. So once again, that's why we use it as a routine test for patients with diabetes. I'm not saying there are any other studies for the kidney. There are other studies for the kidney to test if diabetes is already affecting it, but microalbuminuria is probably one of the most important ones. So we need patients with diabetes to go with their physician, test or do these types of tests. And once again, if we detect the kidney damage at the beginning of the disease, we can stop it through drugs, through diet, through physical activity, through being more demanding with the glucose levels and ensuring that we don't have those large peaks of glucose in our bloodstream. And we can prevent patients from needing hemodialysis or the peritoneal dialysis or any modality of dialysis along the line. If we don't detect it, once again, just as we said with our eye complications, it can be too late. And in that stage, we can't do anything to prevent it. It will arrive to needing dialysis, or maybe even we need it right now and patients can't go off dialysis unless they get a kidney transplantation. Finally, we have a couple of very serious complications that are thankfully these two can be reverted. The bad thing or the disadvantage is that they are extremely serious. They usually merit the patient to be in the hospital and usually in the ICU, being taken care by super specialists in these types of diseases. And we are of course talking about ketoacidosis, diabetic ketoacidosis, and hyperosmolar coma. These are characterized with very high levels of glucose in blood that lead to a lot of complications in the patients. As the name says, diabetic ketoacidosis is characterized by very high levels of acid in our blood. That is of course not good, and it's borderline a patient that is dying, so we have to be very aggressive with that type of complication. And hyperosmolar coma, it's a patient that is literally in coma because all of the glucose causes dehydration of our brain. Once again, it's extremely serious and a very severe complication. We have to detect those very early in our patients and revert these severe alterations. Now, in a patient with type 2 diabetes mellitus, it's usually because of a poor metabolic control. So we find really high levels of glucose in blood, over 200 milligrams per deciliter. In a patient with type 1 diabetes mellitus, it's not so easy. We are more frequently finding it, even if the patient is being managed, because number one, it's usually or it's sometimes the thing with which patients debut. So the patient arrives to the hospital with a diabetic ketoacidosis, and that's when we know the patient has type 1 diabetes mellitus. Once we give the patient insulin and we give him or her all of the things they need to be treated, it's less frequent, it's much more rare, thankfully. However, it may also appear once again if diabetic control was not met in the right way. So these 7 very severe complications is one of the main things we have to have in mind with patients with the diagnosis of diabetes, to prevent them and of course to improve the quality of life of our patients. In a patient with type 2 diabetes mellitus, we have to assume that the moment we do the diagnosis, so if I diagnose someone today I have to check all of these complications. Because since type 2 diabetes mellitus is a very silent disease in the beginning, that patient might have been 3-4 years with high levels or peaks of glucose in his or her blood, and lead to the damage of all of these structures and all of these complications. In a patient that we are diagnosing with type 1 diabetes mellitus, we can have a little while to start checking for these complications. Around 5 years is the time that we will take to start monitoring them. There are some patients that we have to start sooner, but around 5 years it's a reasonable time to start and to, of course, have the patient prepared to prevent all of these very severe complications. Of course, the saddest part of these 7 very severe complications is the fact that if we have a proper metabolic control, if we have healthy levels of glucose in our bloodstream, those are basically preventable. We shouldn't see patients with these severe complications because we can manage them. We can stop them from appearing, and if they appear, we can treat them at the beginning and have patients with very, very healthy lives and quality of life. The great problem, the great tragedy of these complications is the fact that we are finding them late, and then the patients have a very, very poor quality of life. So let's just get checked, talk with your physicians, and monitor these 7 very severe complications to have a much, much better life. That's basically what I wanted to talk with you today on this video. Thank you for watching, and as always, help us change the world, share the information.